increasing demand with the winter illnesses at various practices. And it's time like this, when the expectation is go, 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 and the staff are on do, that we have to make sure we have some time to reflect. So a big thank you to the 500 of you who have registered for this webinar. You do know this is being podcast live, streamed live on many platforms. And your active participation in the session today is what really gives life to these webinar series. I'm Mohit Venkataram. I'm a doctor by background, and I am the Executive Director of Primary Care at East London Foundation Trust. When East London Foundation Trust stepped into the arena of primary care, we were of the view that the role we will play will be one of resilience and support. Much of the architecture of the directorate and the setup is to support the amazing GPs and practices that we work with. And as a large local provider of statutory services, we were of the view that if we shared our corporate infrastructure in a way that added resilience together with the fabulous primary care colleagues we work with, we could create community-based services which were resilient so that our residents could get fabulous care. The creation of this webinar is one such initiative that allows us to have a safe space where we can learn from each other and genuinely realize the policy direction. The phrasing of this webinar as the future of primary care was specifically with a view to recognize that it was not policy that defined the future of how it was delivered. It was us together working within the services, working alongside our residents, our patients, to co-create the future of what primary care would look like, so that we could provide safe services, we could provide good job satisfaction to the people who work within our services, and really good quality for our residents. Today's session, for those of you who have registered previously in our previous webinars, you would recognize, would always start with a reflection on the amazing performance that primary care delivers month on month. But before I do that, I wanted to share a couple of statistics that have been doing the round on various news media. 2.8 million people are not getting through to GP services each month. 1.5 million people said they had to phone back the next day for an appointment. What these stats don't share, though, is the larger picture. Because in the month of September alone, primary care and its wider clinical networks delivered 32.6 million appointments in the country. 40% of these appointments were same-day appointments. 88% of appointments were attended by us. So if the remaining 12% appointments had been released, actually the 2.8 million people who were unable to get through would have been able to get through, most likely. 70% of the appointments delivered of the 32 million were face-to-face appointments. These are sobering facts, and they talk of the enormity of work that goes on in primary care on a daily basis. Clearly, what we are talking today about is using this context and discussing how primary care is evolving. And colleagues, who better to talk to us about the evolving primary care than the amazing Dr. Kiren Collison. For those of you who have known her and seen the multiple hats she juggles, Kiren is the interim director of primary care at NHS England. She is the deputy medical director of primary care for NHS England. She's a practicing GP. Kiren is also the chair of the NHS long-term COVID task force. The list goes on and on. But most importantly, she is a passionate advocate of primary care and has championed the leaders like her who are helping shape the evolving primary care. Before I hand over to Kiren, with a big thank you for coming today, just to remind colleagues, on your Zoom is a Q&A button. For colleagues who are joining on other platforms, I'm afraid I'm not able to help you here, but many of you have already shared your questions. Please use the Q&A button to share your questions so that we can then look at the themes of questions and present them for Kiren to share her views. Kiren, a big thank you for today, and over to you.
Thank you so much. And what a real welcoming, warm approach to starting this webinar. So thank you so much. I'm really appreciative of being invited and having the opportunity not only to go through some of the things that the national team are thinking in terms of primary care, but also to gather some insight and feedback from everyone who's joined. And that for me will be really, really helpful. So I've, although we've been calling it the future of primary care, I like to call it evolving, because I think we recognise that we've been a certain way and done things in a very traditional way, and primary care is gradually evolving over time. And it's not a quick fix, it's not a change from one day to the next, it's an evolution, I would say, of primary care, that we need to take our staff with, but we also need to take our patients with as well. So as Mohit just said, I'm Kiren Collison. I'm a GP. I'm the Deputy Medical Director for Primary Care in NHS England. Been working in NHS England for about 3 years now, and been involved in multiple things, as Mohit described. But one of the things I'm really passionate about is supporting primary care. And I'd like to take you through some key things, which I would then like to get your thoughts and feedback on as well. So if we can just go on to the next slide, please. So this actually very much echoes what we've just been hearing. I wanted to start off some facts and figures and the key insights. And first of all, to say, everyone who works in the primary care setting, thank you hugely, because we in primary care are doing an amazing job. I know we get lots of bashing in the media, we get lots of bad press, which can feel very unjustified, because I know everyone is absolutely working their socks off. And teams in general practice have been delivering 1 million appointments a day, and that's 500,000 more per week than before the pandemic. And I don't think everyone necessarily always appreciates that the activity has really gone up, and that teams have really reacted well and really have managed this demand incredibly well. But having said that, the demand is still outstripping the capacity. So those two columns there, the one on the left, the blue one, that is our current capacity. And what we're doing is we've seen a real increase in the demand coming through, but as a result, we've also increased the number of contacts that we're managing to deliver in a general practice setting. So 20 to 40% increase in contacts. We've also seen a 30% increase in our over 70s since 2010. And we know that that population has 5 times more appointments than younger people. We've seen a 12% rise in appointments since pre-pandemic. But if you look at the workforce, particularly if you look at the GP workforce in general practice, that's increased by 7%. And you can see there's a bit of a mismatch there between some of those numbers I've just said in terms of the demand and then the GPs. And a lot of the feedback we get from our GPs, not just the GPs, actually all staff, is that Workload is a big factor in them wanting to continue in the role. We know that many are dropping in their sessions, and we know we're losing many people as well, but also feeling valued and having autonomy. And these are clear bits of feedback that we get all the time. We can then see the patient satisfaction. And again, Mohit touched on this as well. The patient survey has shown that there has been a drop in satisfaction. But actually, when you look at the reasons why, when people get through on the phone or get through by walking in, get through online, once they get through, they're actually pretty happy with the care that they get. But it's the getting through that is the issue. And that is the main cause of the drop in satisfaction. So if we just go on to the next slide, please. The things that I really want to focus on are those two things. So the ambition is to retain our staff, to have happy, satisfied, real thriving staff so that we retain them and we don't want to lose them to any other country or anywhere else. And then secondly, we want to have satisfied and safe patients as well. Those are really the headlines. But in terms of how do we get there, there are multiple things and no one thing will be the fix for everything, but pieced together actually could help hugely. So I want to just prioritize for tonight's discussion around how we can help achieve both of those ambitions. So the 4 that I've picked here, and there will be many more, but these are the 4 I'd really like to focus on today. Firstly, we know that many of our staff say that workload and the increase in that workload is unmanageable, and that in itself is causing them to feel stressed. It can cause burnout, it can cause people to leave. So we need to look at what the workload is. The second one is around the interface between primary and secondary care. I hear feedback all the time from my colleagues around how frustrated they are about patients having to come back through general practice before being referred back into secondary care, and it doesn't feel like a very streamlined pathway. But I also hear frustration from patients as well when they are bouncing around, and they also aren't clear on when their next appointment is, or where their blood test should be, or when their next scan is, or what their results are. So there's a lot around the interface as well. Safety, I think, is a big part of this as well. Safety both for patients, but also safety for staff. We've heard some really harrowing stories around abuse and violence in practices, whether that's pharmacies or general practice. And so there's a real issue around safety. And then finally, a bit about system working. So primary care can't act in isolation. It needs to be part of a whole system approach, whether that's for managing, for example, health inequalities in a population, or managing system pressures, particularly over winter. And also we saw in the COVID vaccination program, working as a system was really effective. So those are the 4 bits I would like to focus on in particular. So if we go on to the next slide, please. So this is quite a busy slide, but what I wanted to outline here is what's happening already. So this is just a broad background of many of the different things, and you probably will recognize some of them if you're working in a general practice or a pharmacy setting. So many of these come out of the primary care recovery plan, and that's divided into 4 things. The first one is around empowering patients. And just to pick out 1 or 2 of the things there, increasing the self-referral pathways is something that many systems are working on. And that really is to empower patients to not have to go via general practice, but to be able to self-refer into, for example, podiatry, audiology, just to name a couple of examples. There's the other scheme around expanding community pharmacy. And that again that's for your sore throats, your earache, those types of symptoms, which don't necessarily need to come through general practice and could go straight to community pharmacy. This is a way of both empowering patients, but also taking some of that work away from general practice to free general practice up so that it can really focus in on the complex problems, the patients who really need continuity as well. Number 2 there is about a modern general practice. And what I mean by that is really helping patients to understand that things are changing and evolving in general practice. We've got an expanding team of the different roles like physios, pharmacists, for example. We've also got total triage in some practices. We've got care navigation, all terms that actually people might not know what these things mean. But for us working in this way, it can help to streamline the way patients are seen and dealt with. So not everyone needs to be automatically booked in with a GP, for example. They could see the physiotherapist, they could see the pharmacist, or the mental health practitioner, or the social prescriber. It's also our responsibility to inform patients that things are changing. And I will come back to this point in just a moment. Third one's about building capacity, so growing our teams, but also retaining our staff, not losing them. And number 4 is about cutting bureaucracy. So again, lots of feedback we get is around filling in lots of forms, paperwork, things that don't feel necessary or don't add value. So how can we reduce that? The primary secondary care interface work, I think, is a key part of this. But not only that, it also is for patient benefit, as well as cutting out any bureaucracy. It's also very much for patient benefit so that they can have that streamlined pathway as well. So if we go on to the next slide, because what I'm going to do is I'm going to pick out a couple of those things, and I'm going to start with the interface. And the reason why I want to really focus on the interface is because I think every time I get feedback on how things are going in primary care specifically, one of the things I always hear is about that interface issue. And the Academy of Medical Royal Colleges were commissioned to do this report. I hope you've seen it, and if you haven't, please do look it up. It's called Working Better Together. And this was a huge project where they went across the whole country, engaged with systems everywhere, and asked them, what are the problems at the interface? But not only what are the problems, even more importantly, what are the solutions that you have devised that are working? And they got lots and lots of feedback, and that has made up this document here. If we just go on to the next slide, please. This document has 50 examples in total, and they're divided into different subcategories. So they come under culture, communication, and clinical process, because those are the themes that they fell into. Hope everyone can see the slide okay. It's a bit fuzzy on my screen, but hopefully for others it's okay. Mohit, is the screen looking clear for you?
It is absolutely fine.
Now, lovely, thank you. So yeah, that's fine. We can carry on to the next slide. Thank you. That's the one, perfect. So the reason why I wanted to highlight that report in particular is because it has a huge amount of really great examples of how things are working. But the question that comes back often is, this is all really good, this is all really helpful, but we've known about a lot of these issues for a long time. What is different this time around? And I think that's a really valid question, because we know that these issues have been here, but we do need to get on and resolve them. So the thing that is different this time is that we are really trying to put a drive, a real push behind this. And ICBs have now been asked, they've already been tasked with working collaboratively with secondary and primary care to establish local mechanisms where they can really come together and discuss what the issues are in both directions. It's not just a one-way street, but to talk amongst themselves and with their LMCs and really start tackling these issues. We've also asked ICBs to feed back in their autumn boards, so around now, on 4 areas in particular. That's on onward referrals. So what that means is if you refer a patient into a hospital and just say it's for a knee replacement, for example, and they're seen in the hospital and it's deemed that they also need some physiotherapy. What sometimes happens is they get referred back to GP to say, can you now refer to physio? But we don't need that extra step. What we're asking is, please, if it's for the same complaint and you can refer from secondary care, please do that direct referral, much more streamlined and avoids the bouncing around. Number 2 there is about complete care. And what that means is if a patient has been in the hospital or had an outpatient appointment, clear discharge letters back to general practice are like so important. Some areas are doing this brilliantly already, but others have reported back that they don't have really clear outlines about what the next steps are. Number 3 is about call and recall. So that's if a patient has a follow-up or needs a blood test, that they can be communicated really clearly and directly by the hospital. They don't come back to general practice and say, what do I need to do next? Because actually we don't know as GPs necessarily what the plan is, and having that direct line is really helpful for patients. And finally, having clear points of contact. So if there are any areas that need to be clarified, that there can be really clear routes of communication with each other in primary and secondary care, so we can clarify those quickly rather than chasing around, phoning switchboard and being put around all over the place. It's for clear points of contact. So that's what we're asking, but the bits at the bottom, the bits in bold and in capitals: culture, relationships, and strong local leadership. This is going to be absolutely key. And these are the things that have enabled change to happen. So the examples in the report, in the Academy's report, they came about because there was a culture change, because relationships were good, and because that leadership was strong, that they've been able to drive that forward. And if we don't have those, then it's going to be much more difficult. So it's a hearts and minds piece, as well as a technical thing about trying to achieve these specific things. We're developing a network of people who are particularly interested in this, particularly in ICBs and secondary care, to help drive some of this. So if anyone is particularly interested, happy for you to contact me, because really trying to get some drive behind this so we can really see some change. So if we go on to the next slide, please. I want to talk a little bit about modern general practice. So what does that even mean? This is a new term that's kind of been bandied around, and some people understand it, some people less so. So I just wanted to clarify, what are we talking about here? So this really is the process of patients being able to contact general practice. And as we all know, and as I mentioned at the beginning, the satisfaction rates went down because that access was proving to be really difficult. So this is a process whereby patients will be able to get contact more easily by phone, online, or walk in the very traditional way. But when they do make contact, what we're trying to say to people is that you will be asked questions by the receptionist, or you will be asked to give lots of information. And that's not because the receptionist is being nosy, it's because it will allow them to filter the requests. So that might be, they might be able to filter things off to the admin staff if it's a very administrative ask, but also if it's something which can be dealt with by community pharmacy or other services, they can also signpost people there. But if they are thought to be needed to be seen, needed to be contacted from the general practice staff, they can also then divert them to the right person, physio, social prescriber, and others. And then they can book them in with that team. So this can help with freeing up time in general practice, so more people can get the help that they need. But what we can't do is devise all these new things, but then not tell patients about what we're doing. This new way of working, this new model, it's really important that we inform our patients of how things are evolving. And the clear feedback we've had is, please, can we do a comms campaign that really helps to highlight some of these things? So if we just go to the next slide. What we see on this slide is this is just a screenshot of an advert that's recently been filmed, and I don't know if anyone's seen it, but it's a really, really sweet advert. And basically what it shows is children in general practice interviewing different team members. So in that picture you can see there, those 3 children are interviewing a social prescriber, asking her what does she do, and she describes the role in general practice. They also speak to the receptionist, who says, I'm not being nosy, I'm just asking questions because I need to know how to divert people to the right place. They also interview a paramedic as well, and you get real insight into what these different roles are. So I do urge you to have a look at that and to share it as well. It's a YouTube link, so you can find it if you type in your general practice team is here to help you NHS. Hopefully you should find that link. It's really sweet, it's really lovely, and it really explains a lot about how our new team is now formed. So if we just go to the next slide, please. So this is the third thing on my list that I wanted to touch on. This is about the safety aspect. Now, on there you can see the NHS Patient Safety Strategy, July 2019. And I don't know how many of you know this document or familiar with it, but you would be forgiven for not being that familiar with it if you work in a primary care setting, or if that's where your focus mainly is, because this document's really, really helpful. It's a great document, but it is very secondary care focused. And so what we're trying to do now is, how can we transfer some of that support around patient safety into the primary care setting? And when I talk about primary care, I mean general practice, pharmacy, dental, optometry, because it hasn't quite been, the focus hasn't been there as much as it has been in secondary care. But this document is good, and we are using some of the same principles around insight, which was is the 3 I's. So insight, that's around understanding safety and drawing on lots of intelligence to work out what might be not quite working in the way it needs to. Involvement is, who do we need to involve and how do we upskill people to be able to improve patient safety? And the 3rd I is improvement. How do you then design and supporting programs to enable this change to happen. So we over the last few months, we've had some workshops with providers and commissioners in primary care to draw on their insight about what do you need to support you in terms of safety. So it's a real ground up effort. That's not yet been published, but we are looking to produce something. So watch this space on the safety aspect. But one final point on this, it's not just about safety for patients. We have seen these horrific attacks in some settings, and we need to protect our staff as well. So it's also about staff safety. And I think that's really important to emphasize too. So if we just go to the next slide, please. So my final point is about system working. We can't work in isolation in primary care. We're part of a bigger system. So that might be in many things. I mentioned before, it could be about tackling health inequalities in a local population. I've given an example here of winter pressures. So last year, all systems across the country set up acute respiratory infection hubs. And it was a great response, but it was a really necessary response. We had soaring demand of respiratory infections last winter, which I'm sure you'll remember. Group A streptococcus really soared, and there was huge pressure across all aspects of the NHS. And you can see in that graph there, the real peak in December, way above anything that we've seen before. But what systems did is they came together. They didn't say this is just a primary care problem or this is just a secondary care problem. They came together and developed hubs. Some hubs were done at scale, so across 250,000 populations. Some were in more sort of rural areas, more boosting of local capacity in practices or PCNs. Some were co-located with A&Es. There was various models depending on local circumstances, but all there for the same purpose. Because we'd seen the pressure on A&Es, we'd seen the GP appointments go up, something needed to be done. So if we just go on to the next slide, and what I want to show on this next slide is we did some evaluation on this, because rather than just setting these all up and then wondering whether they really made a difference or not, that didn't feel like a very satisfying way to do things. So what we did, we put evaluation into these hubs right from the beginning, and these are our results in a nutshell. So 730,000 appointments were delivered over a 4-month period. And when you compare that to what A&E saw for acute respiratory infection, that was 450,000. So the activity in these hubs was significantly more. The evaluation clearly showed that ARI hubs, or acute respiratory infection hubs, reduced pressure on A&E, freed up capacity in general practice, and improved same-day access. So what that shows is this was a system response to an urgent matter that benefited multiple parts of the system. This, as I said, it wasn't just about one sector or the other. It was everyone coming together to create this pathway that then had phenomenally good results, really, really beneficial. We go on to the next slide, please. So this is just back to my original slide. What's the focus of today? So I focused on those 4 points, those 4 bullet points: the workload, the interface, safety, and system working. And actually they all map back to the 2 ambitions at the top, the staff retention and also the satisfied and safe patients, because they all link into trying to have a healthy, happy, retained workforce, and also a healthy, happy, satisfied patient as well. So I think just final slide is the next one. I've said this is just the tip of the iceberg. I've covered a huge amount in what I've said, but there's always more. I've mentioned health inequalities, I've spoken, but I haven't gone into that in detail. That's a whole other thing that we could talk about, but this is just the tip of the iceberg. But what I would be really grateful for is any suggestions for any ongoing support that you think primary care requires, or any further improvements, or any great work that you're doing that you'd like to share with the rest of us. So thank you.
Oh, fabulous. How absolutely fabulous. Thank you, Kiren. Sorry, if you could take down the slides. I'm scary enough once. I don't want to see myself twice. Thank you. So some amazing questions. I mean, you can see how engrossed people are in the chat with the number of questions that come in. And it is fabulous to see it absolutely abuzz right now. So Kiren, I think clearly you have very eloquently spoken about the evolution of primary care and the new roles that are coming in and how we should be focusing on getting the best out of them. there are some questions in the chat around the restriction currently on those roles. What can be constituted as an R's roles? What are they? And I know there are lots of conversations happening nationally around expanding it in a way that makes more local sense for how the resource is used appropriately. Do you have a view of what's happening, the timeframes, so that people can then reconstitute the R's funding in a way that's appropriate for local needs? Of course, keeping in mind that there still has to be some national tenets that need to be addressed.
Yeah, so when the arts roles were set up, it was done 5 years ago, and it was done with very much clear boundaries in terms of this is the funding, these are the roles, and this is what we want to see from those roles. It was very well defined. What we have seen over time, even though that was set at the beginning of a 5-year contract, we already saw evolution within that. So we've added in additional roles to the original ones that were there. Some of that includes, for example, leadership and management, because that was a direct response to what people were asking for. So there has been an evolution of that. I think going forward, there is definitely the commitment to keep the roles, because they make up such an important part of our teams. They really have made up a vital part of our PCN teams. We are in a point that we haven't got the confirmation about where we're going in terms of what the funding will look like going 5 years forward. But what we do know is that there is no intention to remove these staff. These staff will stay, they're important, we need them, they're working well. But in terms of actual numbers and funding, that is not yet confirmed. But I want people to be reassured that there is no talk of removing them or anything like that. They really are an important part of our workforce.
Fabulous. I think you've touched on a couple of other questions that I hadn't yet spoken about, the continuation of ours. And clearly, ours have become part and parcel of how primary care is delivered, and they do an amazing job in the practices. But there's also another stream of thought that's coming out around primary care today is so different from primary care yesterday, and it has got all these wonderful roles that deliver some great stuff. But not every patient understands the value of them because they are new. In the old days, I remember when I trained 33 years ago as a doctor, you had a doctor and you had a nurse. Now you've got so many roles, and they add such amazing value to patients. I have to say, I shudder to think why we didn't have clinical pharmacists in those days, because they would know so much more about medicine than I would ever know as a doctor myself. So I kind of sit back to think, how should we support the general population to recognize that actually getting care from the right professional is more important than seeing always a doctor and nurse, because that does become a bone of contention at many practices for receptionists to then have to manage something which is inappropriate, because actually as a doctor, I wouldn't want to see the repeat prescribing. The pharmacist does a much better job than I would do it.
Absolutely. And I think that comes back to, I had that slide on modern general practice, which was that sort of flow diagram, which kind of maps out the different parts of the process, which, you and I as GPs working in a practice, we might go, oh, this all makes sense. Yes. But actually, if you're not in it, not working in it, it's really confusing. And not just in general practice, but the whole NHS can be really confusing from a patient perspective. So it really is our responsibility to try and inform people about how things are changing, and not only how, but why they're changing, so people understand you're not being fobbed off if you're seeing a different person to who you thought you'd see. Actually, you're seeing them because your need will be met best by them. So that's also why there's the comms campaign that I touched on, because we've had so much feedback to ask for this, to say things are really changing. We need to bring patients with us because they won't understand, and understandably they won't understand because it's very complicated. So that's why the advert I just mentioned, that's only one part of it, but I think it's such a key part, and it is such a lovely advert. I hope it gets out there more than it currently is. So everyone, please share it if you find it helpful, because I think that helps to answer some of the questions you were asking about. Why am I seeing a physio? I thought I was seeing a GP, but there are very clear reasons for that. And also some of the feedback we've had is from patients saying, well, why am I being asked so many questions? It feels a bit invasive. Again, it's all highly confidential, and it's purely for the reason so that you can get the best care that you need from the right person. And also, if we can direct people to the right place, it means it frees up others. So if as a GP you're seeing lots of having to do lots of queries around medicines, but actually the pharmacist could have done that, it then frees up the GP to do other things, to see patients that need that continuity or have real complexity who needs a GP. So it's around using your workforce in the most effective way.
I think that's beautifully said, because there's a responsibility. This ad which you touched on during your presentation was very touching. It was very nice to see young kids at that age get influenced and recognize the wider roles that people can see. But I think there is also a responsibility in us as citizens to be able to share wider with colleagues the right approach to the emerging primary care, because it is different and it's the right new approach where people get care quicker, faster, more appropriately. I think that there are a couple of questions also that come out with the R's funding. So having clinical input, more clinical input, is just fabulous. But one of the challenges that is stretching many PCNs, I mean, I'm part of 5 different PCNs, many colleagues have spoken, and I think there's someone who's also posted a question on this, is the stretch it is having on primary care estates. And that is a growing issue. And there was a time when you had 2 R's colleagues and you could always house them and find clinic space. But as the growth is now 5, 7, 9 in large practices, it is challenging the amount of estates and premises they have to deliver more clinical care. Do you have a view? Is there an emerging thought about this?
Yeah, such a good point. I know we talk about estates a lot, actually. I know all of us have been for quite a long time, actually. Yeah, so I mean, my view on this is, well, there are a few things to say on this. One is that, there's something about, can we use our NHS estates? So not just that's primary care, this is secondary care, that's community services. Is there any sharing of space? And this is about trying to cross boundaries and be viewed as one NHS together. So there's a bit about that. The other part as well is we're seeing some models as well where they're using space more effectively, so being more efficient in space. So I know some practices say that, someone's room might be their room. When they're not there, it remains their room, no one else goes in. I think most of us have probably been pushed to a point where that perhaps doesn't happen as often, and other staff will now use that room, but that still does go on, though, that it's their room, it's locked up, they leave and they're not there and it's not used. So it's a kind of efficiency of use. ICBs have also been asked to look at their primary care estates and really start to do an analysis of what's there and what's needed. And that's taking into consideration using space efficiently, looking across the whole NHS, looking at those who are actually doing more virtual type consultations where they don't necessarily need a room of their own. Some people working in a team, in a room together, which actually has a lot of advantages, because not only does it save on the space, but actually then you're in a team. So if you do need a bit of advice, you can just tap someone on the shoulder, and it's a real team vibe where you can get that support from others around you. And I've seen some great examples of that happening. It's a little hub of activity where there's lots of virtual calls being made, but with that support around them. So there are actions being taken to look at that, and ICBs are now looking at that, but it probably won't be solved quickly. I mean, to expand estates, update estates, obviously takes a lot of money, and we know there's not a huge amount of that around at the moment, but it's definitely something on the radar that is being looked at.
Oh, fabulous. I think folks would take a lot of comfort with the fact that it is being looked at. There are no easy answers to these things. I mean, let's be honest, we couldn't just build tons of new estates, but at least if we know things are being looked at, there's a recognition that is becoming a pinch point for most places. And you're right. It's quite interesting how estates belongs to secondary care, community care, primary care, mental health. It's actually NHS estates. We need to use it better for all of us, and we do need to think better about it. It is public money. So I think it's really well said, and it'd be great for an ICB to take a neutral view on what the estates are for us to use it better for everyone. And I think from the ICB also stems the other question, which is around the financial challenge in the current NHS. And I think it's less around the financial challenge that I am going to ask the question around. We all recognize that if we want to get services right, the investment should be into primary community services, because the more you provide care there, and your slide around the acute respiratory illness is a really good example of setting up those centers in the community setting, takes away the workload from secondary care and also provides care much earlier to patients, to our citizens. So unfortunately, but you and I know from history, I mean, lived around this long enough to know when money gets tight, the focus doesn't stay on what's the right place to invest in, and it actually ends up going towards the wrong end. How do you think can we as clinicians, people in leadership positions, support the recognition supported by national policy to say answers to problems is not around investment to secondary care, but around more primary care being bumped up in a way that the more you invest in certain, I mean, and I've seen this. I mean, there are boroughs where I've seen there's at least £100 extra per patient invested in primary care compared to the core contract value. And you can actually see their diabetes outcome much better, patient feedback survey much better. Effectively, what that does is also reduces the secondary care impact from diabetic amputations, from CKDs that happen as a consequence of this. How do we help so that you are able to be in a position of making that change centrally and us supporting locally?
Yeah, it's a great question about that. And I like to think of it in terms of resource as well. So it might not just be money, putting money in primary care, taking it off secondary care, but actually resource in the round. So how do you use the workforce in the most sensible way? And that might be bringing secondary care people into the community. As you said, diabetes clinics, for example, and that's just one example. There are lots of others where you can use secondary care staff, but in a primary care setting for some long-term conditions to really support the community. So it might be funding, but it's also staff as well. I think some of the traditional contracts we've had don't always allow that easy moving of funds between the two. So that is probably way above my pay grade to be able to start tinkering with contracts. But having said that, what I think we can do as clinical leaders, and what we need to do as strong clinical leaders, is to put the case forward for why investment is needed in a certain way. And that's why I highlighted those acute respiratory infection hubs in particular, and why we made sure we put evaluation in from the start, was because we found really valuably from the data, and as you've seen, as I presented, that it did show benefit in secondary care as well as primary care and for patients. So I think we probably need to get better with our data so that when we as clinical leaders want to present a really good, strong case, we've got the data there to back it up. And we used both quantitative data to back up our findings, but also qualitative data as well. And we've had many meetings. I've had many meetings with various regional colleagues, and some had a really powerful message saying those hubs stopped some of our practices actually falling over in winter. They were that helpful. And you can't even necessarily always get that type of data from numbers, but that qualitative type feedback was so powerful. And I think we need to be harnessing that, the data, the numbers, but also the feedback, and presenting that to our systems, to work with our systems to do what we feel is the right thing to do. So that's where I think we can come into this as clinical leaders.
Thank you. And I think, like you said, primary care has been at the cutting edge of technology for some time. I mean, it is probably one of the first NHS services that was digitized. EMIS System 1 has been around much before many of the secondary care services even had their PAS systems up and running. But one of the challenges of using digital systems, and it's been posted around, is the fact that not always is the information that goes out as text form to patients is based completely on the right information being put in, and sometimes it's not working right. And I think the resources behind the coding, the resourcing behind the information that exists for primary care is comparably less than other places in the NHS. And it causes anxiety for patients. You know how it is. If you get a wrong diagnosis on your text message, you do wonder, my God, have I missed this also? And it's just an incorrect text. Is there any thought process behind investing in the corporate infrastructure of primary care so that it is much better and much more efficiently managed, rather than expecting a GP to have this single part-time coder who comes in to do things, and that kind of thing, which runs in a corner shop mentality, rather than the large-scale primary care infrastructure which the whole our staff is developing?
Yeah, so in terms of there is a digital strategy that is being developed, which has multiple aspects to it, right from your very patient-facing part. So the NHS app probably is one that springs to mind that is very patient-facing, where patients can, book appointments, get repeat prescriptions. They can do it all via the app. And it's done in quite a streamlined way where it works, where people have access to it. There are also ways that practices can communicate as well by a message through the NHS app as well. Having said that, it's still early days. So I say it's there. Yes, it is there. Some people are on it, some people are not. And going back to what I was talking about, the comms campaign and informing people, one of the strands of the comms campaign that is yet to begin is around what the digital modes are, including the NHS app. So that is still to come, but because I think we again have a responsibility to say what is there, how do you access it, and not everyone will find this easy. I mean, my own parents would probably find it tricky. So I know that, and some people are really tech savvy and others just aren't. And so how do we get everyone involved and know what is happening and how they can use it to best effect? But there are other layers to the digital strategy. That's just the patient-facing bit, but there's also a lot of there's certainly a lot of discussion around how do we join things up. The interoperability between different systems is paramount. We do a lot of work in general practice with community pharmacy, and I mentioned before about the rollout of some of the common conditions that pharmacy will be able to start seeing, like the sore throats, the earaches, the impetigo, those sorts of things. And at the moment, we don't have the streamlined IT between us to be able to both enter onto the notes and see each other's. It's at a kind of a rudimentary stage, really. So there's definitely work to look at that and how that can become better. So you can have not only can you read what's in there, but you can write into the notes too. So that joined up care. And it's not just with pharmacy, it's with secondary care as well, because we know you all need to be as joined up as possible. And then, I mean, there is the other part to this as well is, the access to notes. And I know lots of practices have now given patients access to their prospective notes. Not all practices are quite there yet, but some are. But again, in empowering patients to digitally look at their own notes, be able to check their own blood test results, and that side. So there are lots of elements to this digital strategy. I don't think we're quite there yet where every computer and every practice is being replaced and updated. I think that's the dream. It's not there yet. But there are certainly some good steps being taken so far.
I think that's phenomenal, Kiren. The extent of work that's happening in primary care to transform it is phenomenal, but these things take time. I mean, it's never a quick fix. And there's a couple of really good comments in the chat box and in the Q&A. Things around some of the non-value added work that comes to primary care. And I know NHS England's done tons of work under your leadership around non-value added work, getting out of primary care so people can just get on. But one of the things that does hit on the face quite often is this around secondary care sending instructions to GPs to prescribe certain drugs. And with primary care now able to send those prescriptions directly to pharmacists, wouldn't it be so much easier if secondary care just sent it to the local pharmacist rather than coming to the GPs to have to re-prescribe? I know it's only a 10-minute appointment, but actually every time that happens, there's someone who's missed a 10-minute appointment who could have been seen by a GP.
Yeah, absolutely. And so that's why big part of what I was talking about was the interface. So it's probably the issue that comes up one of the most frequently, I would say, both in terms of administrative things coming through that probably didn't need to, but secondly, a shift in what general practice is being asked to do. And I think a lot of that came since the pandemic, actually. People thinking, hang on, why am I being asked to request that scan or do those blood tests? So there are two elements to this. And it comes back again to what I was talking about, the interface and what we're asking ICBs to do. There are some very specific things on there about, like, for example, a Med 3, a fit note. We really want secondary care to be able to do those, not send them back to general practice. Things like that. The e-prescribing is key, but that does rely on having the right digital infrastructure, which isn't always as straightforward as we would hope. But ultimately, a lot of what we're asking of ICBs is to set up the infrastructure to get those conversations off the ground, and in a really collaborative way. We don't want people just finger pointing and saying, oh, you're doing this, but you're doing that. We want people to come together to genuinely share, this doesn't work for us as staff and it doesn't work for patients. How can we make the patient in the center so that and then we work around that to make it more streamlined for everyone. And we want those conversations up. And nationally, we're not going to dictate how it's done because everywhere is different. And it's for those local relationships really to develop. And that's why I talked about the culture, managing to do that cultural change, develop the relationships, and be able to drive this forward locally. And a lot of trust, actually, between the two settings, so that we're all working as one big team and trying to work it out, rather than don't give me this and don't do that. And we don't want that. We don't want that.
And I think you also touched during your conversation very eloquently on safety. And I think it was brilliant to hear about the safety element, because in the secondary care services, PSERF is being rolled out quite actively with a view that would become the platform to engage every clinician across every system. Is there a view that PSERF would also be mandated or implemented through the new PCN contract?
Can't speak for the contract specifically, because we're not at that stage of talking contractual. But what we've tried to do is, because of the safety strategy is very focused around secondary care, we're trying to take out some of the parts of that can relate to primary care. But what we're trying to do is create a really safe, supportive environment so people feel there's no blame. It's about sharing, it's about learning. And I think what we see at the moment largely is, in a practice we might share amongst ourselves as colleagues in a practice, but I don't think we tend to share much outside our own practice with our PCN, with our system, with our ICB. That tends to be more limited, and that was definitely the feedback we had from the group that we pulled together and had workshops with. But we did get some really good examples of where it is working well, and community pharmacy gave some great examples where they all come together from local areas and discuss their cases in an anonymous way, just to share and learn. And it's that learning environment that we want to set up. So it's not so much about, it was definitely not about blaming anyone or anything like that. But we also recognize as well that everyone's under a lot of stress and strain, and capacity is definitely constrained. So what we also don't want to do is put lots of things in place that are mandatory and contractual, that then mean people have to tick lots of boxes, because it's not around that. It's just about a culture, developing a safe environment where people can speak up, share and learn. So that's the space that we are currently in.
Fabulous. How absolutely fabulous. Clearly you already spoke about the digital literacy, which does sometimes impact patient care, and you spoke about your parents, and you're right, some people find it easy, and I have to say there are things I find easy taking up, there are things are not, and I think we also have to support you in helping you find the right answers to these questions, because there are no straightforward questions. I think the good thing about this space is it's not about you having to find all the answers, also about the 500 of us who are logged on today to come up with some solutions based on feedback we've had from our patients and share it with you. So colleagues, if I may just say, firstly, thank you for the absolutely fabulous questions, because that's what keeps it live. That's what keeps this session so active and such fun to be in. But more importantly, also a big thank you, because Kiren has openly said, if you have solutions to what the emerging primary care should be, do get across to her. She would love to hear from you if there are good practice examples happening. And many of you in the chat box, as well as the QA, have put some really good examples there. So please do that. I think it's really hard for me to summarize a session like this. It is really hard when the session starts with an explosive 500 people registering to want to be part of this. When a session starts with such massive data and information that you shared, Kiren, which was phenomenal, really heartwarming to see the extent of work that's happening in primary care. And then some really key things that you touched on today. Empowering patients. Always something that's very close to my heart, because actually we as patients, not as clinicians, should lead what's the right future, because we are the ones who can dictate where things are going wrong. There are questions that are asked about confidentiality. It is for us to ask our GP practices that if I'm sharing additional information on the reception, I don't feel comfortable, please create the reception that's safe for me. And I think it's brilliant to hear that. I love the slide bit about cut bureaucracy, because actually the amount of waste we put in because of bureaucracy is an absolute waste to the NHS pound. We should look. And strong local leadership, always key in delivering good services, because one of the things I loved about what Kiren said was, you can't dictate nationally only one way of working, because the answer lies locally with the people and the local clinicians, and each place has a different answer. And that's the beauty of providing services nationally. So such powerful information, such fabulous words. I can't thank you enough, Kiren, for what you have said today. And thank you for your time. It's been brilliant. I also want to just remind colleagues that you have feedback that Sarah has already posted very quickly. And I wanted to say a big thank you to Sarah, because Sarah was working with Nikki. Thank you to Nikki who logged on, but Nikki's computer crashed. But none of us recognized, because Sarah just beautifully continued. So Sarah, a thank you, because without you, we couldn't have run this as it has run today. Colleagues, please do fill in the feedback, because it is your feedback that dictates how we run the next sessions. And we use that to keep fine-tuning this. I'm ever so grateful to that absolutely amazing evening. And Kiren, thank you once again for your day.
Thank you.
Sarah, could you switch this off, please, so colleagues can take away? And Kiren, if you stay for a moment.